This time last week, the federal government had just about inked an agreement with the premiers for its health reform plan Mark II. Now the Business Council of Australia has weighed into the debate with its own report on what should happen to the health sector. Its mark for the government's plan says, good start. I spoke to the Business Council of Australia's spokesman on health, Rohan Mead, who also runs the big health insurer, Australian Unity. Rohan Mead, I've read the Business Council's report on the health sector. It's full of unarguable sounding phrases like the need for microeconomic reform, put patients first, prevention rather than cure, focus on outcomes. But it seems to me short on actual specific suggestions about what needs to be done. Do you have any?
Well, I certainly do, Alan. And I think the issue, though, in the past has been too much of a grasping for the total solution in some sort of package. This is a very, very large sector, 10% of the economy, more than 10% of the workforce. It's growing at $10 billion plus, accelerating per annum. And in that sort of context, the idea of being able to sort of specify the remedy for the sector's ills all at once is, I think, has been part of the problem.
I'd settle for a few little ones just along the way rather than the entire.
Having said that, I think we do really need to make sure that we start moving away institutionally from a system which is focused on activities.
But what should the federal government do apart from that, the recent reforms which are focused on outcomes, as you point out? I mean, it seems to be based on the Victorian system of case mix funding, where funding is applied according to the procedures. An efficient cost of the procedures. Is that wrong, or should they do something else?
It's absolutely right. It's something to be welcomed. Activity-based costing is part of this solution, but it's necessary, not sufficient. Being in a position where we can understand when we add $1 billion or more to the public hospital system, understanding a little more what we actually get out of the public hospital system as a result, how many hip operations, how many heart operations, that's all vital underlying data. And we don't have that today, and that's part of the problem. So when I find out a little bit more about heart operations and knee operations and what's going on in the acute hospital sector more broadly but with more granular detail, I can start saying things sensibly about what should our complication rates be, should we be achieving in terms of trying to bring patterns of disease more in line in one community rather than another. Are there things that we can learn from this information? So it's an important first step. But it's by no means the end of the reform road.
But are there any specific things you'd like to see done?
We need to do some institution building in this area. We need things equivalent to the Productivity Commission and the Reserve Bank and APRA in the health world. It's 10% of our economy and it doesn't get the sufficient attention that it needs to. And we need these organisations, these institutions, to be sufficiently well established and entrenched with statutory protections so that they can stand up to powerful interest groups like governments, who are, of course, very conflicted as funders and providers in the healthcare arena.
There's a diagram in the report talking about turning the healthcare industry on its head, with patients being on top instead of on the bottom and specialists on the bottom instead of on the top. I was just wondering, what does that mean? How would that look like in practical terms?
Well, imagine a situation where someone has a complex specialist need, such as a complex fracture, broken ankle, that sort of thing, that needs a specialist to attend to it. Well, that still needs to happen, but we also start needing to look at the person as a whole. Is the cause of that fracture some osteoporosis, other types of diseases, which also need to be treated? And in fact, to make sure that there is no reoccurrence of breakages, do we need to do better? That's the sort of orientation we need from the system.
Isn't it possible that what you're proposing would cost more? And I was struck by a statement in the report that said health is a superior good and therefore the proportion of expenditure is irrelevant. And so it seems to me that if you're overlaying the cost of holistic care on top of what we currently have, that would be more expensive, in fact. And the whole purpose of the exercise is to restrain costs, health costs, I would have thought, as the population ages.
Well, there's a couple of things in that. Firstly, the current system, we'd submit, doesn't manage its own current inefficiencies particularly well. So, yes, there is likely to be some inflation in costs in some areas. But if the value of the activity increases as well, that shouldn't worry us. This is not about just a cost control mentality. This is about trying to drive better community outcomes, better patient outcomes, and therefore better value for the system overall. Sadly, where we are at the moment is that governments and other major funders are in the business of cost control rather than patient value. So if we actually address a changed orientation, we should be able to see a much better value equation. Similarly, we should be able to make the system look at its efficiencies and actually seek to squeeze out its poor practices and replace them with better practices that also comprehend not just one instance of disease, but someone's whole lifetime experience of health and ill health.
Thanks for joining us, Rohan, Mead.
Thank you.